oxygen or any such facilities. It is not meant to have that. It is just a handover area. So once patients are resuscitated, they go to the buffer zone where the handover takes over, and then they are shifted to they are shifted to their respective destinations. So again, while we are all planning a mass casualty, we are making a mass casualty plan for our institutes. The one thing that everybody needs to understand is what area should become the red zone. As per the WHO mass casualty management plans, it is said that all existing emergency department, the entire existing emergency department has to be converted into a red zone. The green zone is usually located outside the emergency. It can be it is usually a covered area which is outside the emergency. OPDs might be used for that. Waiting rooms might be used for that. Cafeterias might be used for that, which is called the green zone. In the green zone, once the patient comes, so there are setups. There are actually setups like you'll have one station for wound care, one station for plaster, and one station for ENT examination. Following all, once the patient visits all three stations, if they are found clear, if everything is done in all these three stations, they are subsequently discharged from the green zone. Now, again, the most important thing is again to maintain during a mass casualty is while we are actually locating our green zones and red zones, there should be a unidirectional flow. So like there should be no crossover. So no crossover. There should be a separate entry and exit, and green zones and like the entry of patients of red zone and the entry of patient of green zone should not mix at any point. Family area is usually located outside the emergency near the green zone. Media, again, far away from the emergency, actually away from the area where the patients enter. And the staff pooling area is somewhere near the red zone. So this is just a brief review of the concepts of how various zones are allocated during a mass casualty incident. What are the zones? Red zones, green zones, and buffer zone. And what do these zones need to have? So a green zone will need to have a kit which will have all the supplies ready. So green zone, since we are planning to do only wound care, only splinting and ENT examination, so all those things need to be available there. Along with that, we need patient tracking forms, we need documentation forms as to which patient came, what was, since it is a mass casualty incident, we might need medical legal documentation as well. So documenting that, and we'll need quick documentation forms, identification forms, and discharge forms. So this is what will be there in a green zone kit. A red zone kit will have all the resuscitative equipment which is required normally to resuscitate patients to manage airway, breathing, and circulation. So while we are preparing for a mass casualty, it is important that a green zone kit and a red zone kit is already kept ready in your institutes as a part of baseline preparedness. So these are the things that we need. Red zone will have equipment for life-saving interventions. Green zone kits will have equipment for minor injuries. So we'll have for minor injuries. This is a this is a so I'll just this is I have a very short presentation for this. Anything
Hi everyone, Dr. Ankit this side. So, Dr. Charu, can you hear me?
Yes, I can hear you.
Yes, sir.
Yeah.
Thank you
So,
very much, sir.
hi. So, just to add some few points specifically in red zone, as we all our participants are nurses, so we have to know how you are going to post everyone. Means how many nurses in the red zone, how many nurses in the yellow zone, and how the process will happen. So, I think Dr. Charu, you can you discuss that how the teams will be made and how in the red zone they will do what is about the resuscitation way. So, I think we'll discuss that.
All right. So I'll go for the red zone part. Okay, I'll go for the red zone. Just. So when we talked about red zone, our main goal here is to perform resuscitation. So red zone usually has this red zone usually has the same number of we usually make people we have nurses posted as teams. So you will have one doctor along with one nurse as a resuscitation team in the red zone. Whereas in the green zone, for a lot of for wound management and splinting, you can have more number of nurses, and actually lesser number of doctors can be posted. Also, the green zone will have more number of patients, so the number of nurses needs to be higher here, because it will help in both patient flow and crowd control. So the number of nurses will be more in the green zone. So you'll post actually more number of nurses in the green zone, but in the red zone, the posting of nurses will be the nurses and doctors will be as teams. So you will have one team in which you'll have one doctor and one nurse who will be responsible for resuscitation, and that's how we proceed.
Yeah, that's the great thing. The point is, what we want every of the participants to know that, see, this is a mass casualty management, so you are not going to give the standard of care. For example, if a patient who has come with a polytrauma, for example, there may be two doctors, two nurses, and some other staffs who used to manage a single patient. But in this case, always remember, you have to make a team and you cannot divide the team. So what do you mean by team? As Dr. Charu has mentioned well, is like one doctor and one nurse is one team. So for example, in a resuscitation bay, for example, in your red zone, there is a resus bay where you are going to receive the patients. So once the patient enters, first patient enters, which is a non-working patient on a stretcher. First clinical team, that is one doctor, one nurse, will attempt the resuscitation and do all the ABCD part, only limiting to the basic primary stabilization. Now, once the second patient comes, the second team, if can be made, another doctor and another nurse team, means doctor one, doctor two and nurse two, should be the team two who will be resuscitating the second patients. But for example, the third patient, fourth patient, fifth patient, sixth patients are coming, you should not divide your team that, like for example, one doctor will tell nursing officer, please go and see the third patient. You should not divide, because you will not be able to give care to each and every patient. So if at all you have two teams in the resuscitation bay and two patients are being simultaneously resuscitated, third patient has to wait, and once the team is free, then the third patient will be taken, then the fourth patient will be taken. So please remember, in the MCM you have a very limited capacity, limited manpower. So one doctor and one nurse is a clinical team, which are bound partners, and they have to see one patient at a time. So that is what is a red zone process means. And I feel like that is the most important thing that we should know about the red zone. As ma'am has already told you about the green zones, I think, yes, you may need to keep more nurses there, for example, for wound management, pain management, and some other things, fracture immobilization. More nurses can be posted there, but for the red zones, you have to post adequate nurses, but as a clinical team. So I think any questions we can go through.
We can go through any
Yes,
question.
sir. Yes, ma'am. There is a one question by Sudipta, ma'am. She asked, in which situation patient can be shifted from green to red zone, ma'am?
Okay, so this is a very good question, ma'am. Ma'am, a lot of times we'll have patients who will be walking initially, but while you do further examination, you might find that the patient might have an injury which is life threatening. So it is possible, if they come very early after the incident, they initially might not have any injuries, but while you're doing an examination, you might suspect that they need observation, or maybe observation, or maybe an investigation, for which they might need to go to the wards also. So for those patients, we'll actually send them from the green zone to the red zone. They will be again evaluated by the red zone team. They will take a decision whether to send the patient to the OT, to the ICU, or to the wards. Am I clear with this, or any other anybody else would want to?
Yeah, Elsa here. It's very nice presentation, Charu. That communication will be a big chaos. So how do you go about doing that?
Communication, if you want to communicate, like communication during from in the zones, or like exactly where, ma'am?
Well, the mass casualties are arriving and then
Okay.
going to various areas, whether green zone, red zone, or wherever it is. So
Okay.
how the communication has to flow.
How the communication has to flow. All right. I actually, how the communication has to happen. So actually communication during a mass casualty, there are various things that can be used for communication during a mass casualty. So a siren, a computer announcement, usually we don't rely
So
on mobile phones, because we expect that during a mass casualty, even our services of telephone and internet might also be hit during that. So we usually rely on maybe sirens, maybe PA systems to communicate, and to actually mobilize the teams which are in the hospital. So our first goal is to actually mobilize teams which are in the hospital to create these zones, and maybe then if we can get further teams, we can mobilize them and use them further. So the basic goal is, while we are testing our plans and while we are making our plans, we need to have an alternate system of communication which is different from the usual system, because we expect that during a mass casualty, our usual system of communication will be hampered.
yes, thank you, Charu, and I am Dr. Tej Prakash. Thanks, madam. Probably, madam wants something more.
Okay, sir.
So, during communication, in communication, during mass casualty, what we require? One is activation. So, Dr. Charu told about how to activate, how to communicate that mass casualty management plan is activated to other members. So, that is the way. So, it can be a PA system, it can be a mobile based message, it can be a dictaphone. So, whatever works is useful. But many times, we know that communication system, usual communication system like telephones, electricity, they might not be active at that time. Like right now during the war, this Operation Sindoor, the first thing happened is siren is on and light is gone. Siren is on, light is gone. So it is very difficult scenario. So your MCM should have a way to communicate your people, whatever you think is suitable at that point of time. So there is way to communicate. But how we get to know how many patients went inside, who went inside, who is being discharged, who is placed where? If somebody wants to know this patient went to what, who died, who survived, these all are the information things which is required. How much we got saturated. So at each point of exit and entry, at each point of entry and exit, especially the exit, we must have a person who is noting down who has gone outside, who has came inside that particular zone. So that is about not only about the emergency, but to OT, to buffer zone, to ICU, to wards. Okay, so these all must be noted and should be communicated to the incident command system, or whosoever is taking care as in charge at that point of time. So the communication must flow from the ground to the management system, and from the management system to the ground. So you must have a way to communicate in that way. So that is how we get to know how many patients came inside, who died, and further details. So that is how we have a communication system. But Dr. Charu is right in saying that you must have the final robust system, that is the manual way of documenting, the paper-based system. It always works. Then communication is relying on your common system, which is not going to hit. Like the mobiles may work, but the usual landlines may not work at that point of time. You may have runners also. Some of the places or some of the times you may have runners. So runners means आप 2-3 जो हॉस्पिटल अटेंडेंट्स, you can use them. They can just run and go to the ward and tell activated if the system is not working. So that can be a backup plan. Or every hourly report of input and output of each area need to be written on a paper and sent to the command system, so that everybody is aware. So that is how we do, madam. So that's fine, Elsa, madam.
So yes, sir. But yeah, this needs a lot of planning. And if we
Yes,
anticipate,
yes.
I think we need to have some innovative ways to capture all that, because in the real scenario is going to be quite chaotic. So I think doing
Yes.
drills and that coordinated system is important.
Yes, yes.
I know
And
every drill will be perfect, but when real scenario comes, it's going to be something else. So I think we
so
need to put onto our systems.
yes, that's why we need to practice multiple time.
Yes.
And until unless the ground force is aware about those protocols and practices, we are bound to fail. Actually, we as a management system, we used to practice. Who is not working at that point of time. So it is always important to train our people. That's why we have taken up this course specifically for nurses, because they create the chunk of healthcare providers at any given point of time. Thank you, madam. Thank you. Thank you, Charu.
Oh, thank you,
Over
sir.
to you, Dr. Charu.
Yes, sir.
Yeah. Ma'am, Dr. Charu, there is another question. Thank you, sir, for joining us. So this is a question from Mr. Boni Haldar. Could you give example of blue category patient, how to differentiate blue category from the red patient? So it's just to add in your knowledge, this was we discussed in last session,
No problem,
but
no problem,
still
ma'am. No problem.
anybody would like to answer? Yeah, ma'am, over to you, Dr. Charu.
So thank you, sir. So, sir, your question was how do we differentiate blue from red patients? So a lot of times during mass casualty, we might get patients who we might see have no chances of survival. So a lot of times we get head injuries in which the patient does not have any brainstem reflexes, or the patient has presented to us with the GCS in which the GCS of 3. So those patients during a mass casualty actually become blue patients. So rather than again we so again, if we know that the patient actually does not have a chance of survival even with treatment, during a normal scenario we actually keep them in the ICU, observe. We do not we actually do not go for we actually give them the usual standard of care. But during a mass casualty scenario, since the number of patients has increased, and we want to actually save those patients who actually will survive from the treatment, so so in that scenario we will actually not focus both our resources, which is in terms of ICU beds, supplies of medications, and also our manpower. Will not actually focus that on those patients who actually do not have a chance of survival. So a patient who presents to us with a GCS of 3 with a very big with a head injury, so that patient usually will not have a chance of survival, but in usual scenarios we admit them in ICUs. In mass casualties they'll be triaged as blue. So that is one example. Or somebody with very extensive burns. So again, those patients do not have a chance of survival. So, but again, they will require care. They'll require analgesia. They'll require care. So all that will be provided to them. But again, ICU admission might be something which we need to think over during a mass casualty scenario. So we'll provide them. We'll provide them comfort care, but again, we might not go to what we do in a usual situation.
Yeah, so I just want to add, Dr. Charu has described about blue. So again, we always get confused about what is a blue, what is a red, what is a black. So blue are the patients who are gonna die irrespective of whatever you do. Like as Charu has told all those cases. Red are the patients whom you want to save. For example, patient who is coming with shock, but yes, if sent to OT is gonna survive. If a patient who is coming with an head injury, but is a possibility that the patient is gonna survive. The patient has come with a good GCS and is gonna survive. We'll send them to ICU. So these are the patients whom we can save. Last class, people have asked about black category, means whom? Black category are the patients who is dead now. So obviously the carotid pulse is absent. So black is dead patient. Blue, irrespective of whatever you do, they are gonna die. So they need palliative care. Will be sent to a ward where palliative care will be given. Red patients are those whom you are going to save. Those sick patients whom, if sent to OT on time or sent to ICU on time, can be saved. So they will be sent to OT or ICU. So I think, are we clear about this? Blue, black, and red.
Yeah, thank you very much, sir. And ma'am, ma'am, there is another question. How do we prioritize resources during mass casualty, especially in pediatric cases and setting with the limited resources?
In pediatric cases and setting up with limited resources. So the
Yes,
resource management during mass casualty needs to be again we'll need more for our patients who go to the red area. So for that, the resources in terms of I first talk in terms of supplies. So if we talk in terms of supplies, the usual resuscitative equipment will be there in the red areas. Other than that, if we talk in terms of human resources, again, human resources, as we discussed previously also, so our human resources will be, again, we'll have teams of 1 doctor, 1 nurse in our red area. Green areas will require more resources, both in terms of human resources, also in terms of supplies, because we'll have a greater number of patients there. So even in terms of supplies, like the number of the number of bandages, the number of splints, everything will be more, which because we assume 80% of our, and in every mass casualty situation also, we assume 80% of our patients to be green. So most of our resources will be in the green area. So we'll actually need to work on increasing to have a good backup of our green area resources while we are planning for a mass casualty situation.
just to add for pediatrics or any other scenario. Okay. So it depends on what kind of capability you are having and what kind of patients you are getting. Suppose I am getting all pediatric trauma patients. Okay, and I am treating lifetime. I am treating adult trauma patients. My center is capable of treating only adult trauma patients. So what additional thing I will require if a pediatric patient comes? That we have to think. So there will be change in understanding of managing red patient, change in addressing the resources, like Dr. Charu told. So if you have those resources, well and good. If you can bring in those resources in time, well and good. If not, you think what best you can offer to these pediatric patients. Okay, and try to get help for specialized care, specifically for pediatrics. If not, then you have to tell the management that these are the things which we can best manage. So take all those patients, like green patient of pediatric, Dr. Charu told. There's nothing, wound is wound. Okay, the understanding handling the pediatric patient may be requiring certain kind of skills and knowledge, but essentially for wound, splintage or fracture, eye examination, ear, these all will be same essentially. Red patient who are pediatrics, there may be some physiological consideration. So meaning to say, that is a knowledge part, skill part which is required. But yes, the common resuscitation, basic resuscitation, and MBBS doctor can also provide, which is being done. So that way, nothing, a lot of changes in thought process or management system is required, even you are receiving the pediatric patient. So that is how we go about. Thank you.
Much, sir. Thank you very much, ma'am, and thank you very much, sir. There is a last question which I can see in chat box. When we have a mass casualty, a
So
regular
I will
patient
take
in,
this. I have gone through this
yeah,
question. Like somebody may be coming with labor or MI or something else, which is not from the event which has happened. Like some bomb blast happened, and in bomb blast some labor patient comes or some MI patient comes. So first and foremost, they will also be counted as an MCM patient, not as a separate patient. That means they have to follow the walking non-walking pathway. We don't train our staff member in many different ways. They will just go ahead with walking non-walking. They will be counted as MCM patient, and at triage they will be triage 2. They will be recognized that this patient is having chest pain, came walking, so they will be moved to the red zone, and there they will get the initial management. Or if you have some other departments like medicine department or those department wards, ICUs, you can send from there to that zone. If you have the capability to give the loading ECG, that's fine, but we don't waste time in our area for these patients, because you are having lot of injured patient where you have to have your role, your team is tuned, and they can give good output in injured patient, not in MI patient. So better you recognize and send to the appropriate place where you think the further management can be done. But if you are not having the capability, you just send them to the better place where you think maybe in ICU, maybe in ward where the physician is there, they can handle it. So that is how. But there is no segregation that ye MCM ka hai and this is non-MCM patient. All of them will be counted at that moment. Whosoever is coming to emergency is MCM patient. Okay, thank you. Over to Rupa.
Thank you very much, sir. Thank you very much, ma'am, for the insightful, short, concise, precise session. And thanks all the participants for asking such a deep question, which actually इस पूरे topic को समझने में और हमारी help करी. Thanks everyone. Thanks Dr. Ankit. Thanks Dr. Tej. Thank you Charu ma'am for taking this session, and thanks Elsa ma'am and all that other participants who presented today. Thank you very much. Take care. Bye. Be safe.
I will request the
Keep helping
participant.
people.
I will request the participant center, if you wish to make a provisional or a brief plan of your center, you please make it, send it to us, and we can have a small discussion with you. If you require help, we will go ahead with helping you. So you just make your plan now. Many things you know, make your small plan and send to Rupa or us. Okay, so we can just email ID is there, so you can share and we can
Dr.
start.
Tej, Dr. Tej, can we
Ma'am.
also have some sort of that kind of awareness plan for a drill or something?
Sure. You must plan, madam. Idea was to ignite the minds, the brains.
Yeah.
That
I
we
want
are
to
doing.
plan one drill, small, if it is not even massive, I want to do something, start with
No,
something small.
We don't go for massive, madam. Idea is you go for zone wise drills. Go with a tabletop drill. Go awareness sessions for your staff. Then go for tabletop drill, and then go for a small area drill, like just green zone activation. Just tries one activation drill. Just T1 and T2 drill. Resuscitation by activation drill. Buffer zone activation drill. So go for mini drills rather than going for big drills, so that you can do it during your normal day-to-day activities. So that is how we recommend also, and we do also. Okay, madam. Thank you, madam.
Yeah, I will plan and send to Rupa. Maybe I'll take a specific area.
Sure, madam.
Thank you very much, ma'am. Thank you, everyone. Take care. Bye-bye. I have dropped our official email ID. Please feel free to write us email as Dr. Tej said, and in case of any help, we are more than happy to help you all. Thank you very much.